Good afternoon. I'm Dr. Devika Gunasheela, the director of Gunasheela Surgical and Maternity Hospital, and with me is Dr. Jyothi Menon,
Good afternoon.
who is the director of Infertility Services in our hospital and also one of the senior most gynecologists as well as practicing infertility specialists in our state. And I would both of us welcome you to this eighth episode of our
Patient educational
patient
programs.
education programs and called Ask Gunshila. And you can text in your questions at any time during the program. If you want to ask us anything on this live show, can we also have the next slide, please? And that will be like that, I think. I'm not sure. I don't think this is working. But anyway, this is our, yeah, you can text in us our questions to ask@gunshila.com, and we'll be very happy to take them at the end of this program. And this is the second episode in the series of frequently asked questions. So because we were getting inundated with so many questions by patients, we just thought that we should actually talk a little bit more about the most frequently asked questions and discuss them in a little bit more detail.
Yeah, because when we've had our patients coming back and telling us that really, okay, now once we have the IVF, all that is all very fine, we become pregnant. But these are very frequently asked questions. So we just thought that we'll share them with you also. And I think the commonest question everybody wonders is how different is the pregnancy going to be or the delivery going to be than from a natural conception?
Yeah. I think, see, the thing is, IVF pregnancies, when we have a pregnancy, we give them a lot more medication to support the pregnancy, number one. A lot more medication is given to get the eggs out, and it's going a little bit backwards to get the eggs out, and then to make the embryos, and then we have to support the pregnancy. Now, these can cause a few changes inside the uterus and also in the way the placenta attaches itself to the uterus. So that's when we can have certain problems. But really, after the first 8 to 12 weeks, then every pregnancy is kind
Yeah,
of pretty
exactly.
much the same. And
And also, I like what we have had experience with our own patients. These patients have really spent so much in trying to become pregnant,
yeah,
and so we cannot even take that 1% chance of having any problem which is not looked into by the consultant obstetrician,
yes.
because that is the reason why they require much more frequent monitoring. So we call them more frequently. Maybe we give them additional medicine, because at the end of the day we want them to take the baby home.
Exactly, yeah. And so many of our patients, at least in our clinic, are women who have gone all over and tried their IVF cycles in many places and have come back to us as the last resort or the last hope. And they come and tell us, this is our last hope. And I was just seriously thinking about changing our hospital name to Last Hope Clinic, because
Yeah.
because they've gone everywhere and they come back to us and say, we should have our baby from here. So we have people telling us that. And the other thing is that we also have got women who have had 10 years, 15 years, 20 years of experience of childlessness, and we should actually kind of be a little bit more careful
Yeah.
also. And at the end of the day, after you try so hard, if you do actually have an abortion, it is really heartbreaking, especially the ones who have the mid trimester, which is
Yes.
after at about 6 months, 7 months, etc., or even the fifth month. That is very difficult to
Yeah.
stomach.
But we've had patients see even the route of delivery,
Yeah.
whether it's all going to be only cesarean or can you really have a normal delivery. We've had plenty of patients who had normal
Oh
deliveries.
yes, yeah, and I think
And I think our advantage, Dr. Devika, is basically because we look after our pregnancy patients.
yes, most of IF patients come
Yeah,
back to
come back
us.
to
Yes,
us. So I think that's a huge advantage we have, rather than being only an IVF center, because we know exactly what to look for them, when to look for them,
yeah,
and they have built that confidence in us during the IVF cycle itself.
yes, correct.
So at the end of the day, we've had plenty of patients who we've had normal deliveries. But only at this point, what is to be said is, unlike other patients, we have to be little more careful in taking a decision about converting it
See, I
into an operative case
correct.
if required, because like we discussed earlier, at the end we want a healthy baby from a healthy mother.
Yes, correct. But I do think that the infertility patients per se, as a group, are a slightly higher risk,
Yeah,
for pregnancy, because a lot of them are at the, shall we say, the older spectrum, of age,
age.
of
Maybe
reproductive
this is
age.
their only chance.
Yeah, it's their only chance, and also
Yeah.
we do have 41-year-olds, 39-year-olds, and that's not really the ideal time to get pregnant. But then they have spent so much time trying, and then when they come to us, they are at risk. So we
Yeah.
have, we have always been a high risk obstetric unit, and I think as
Correct.
long as our IVF patients come back to us, we still will continue to be so.
Yeah.
Um, so the other thing is that patients come to us, having gone to so many various units, and then now tell us, now what will you do different,
Yeah.
so there have been very many advances in the
Yeah.
IVF technique. So would you like to kind of
Yeah.
talk about it?
See, the advances have been both in the clinical side as well as the embryology side. Going to
Hmm.
the clinical side, right now, what is available is, I think, one of the main problems which a lot of our patients tell us is these daily injections
Yeah,
of stimulating drugs, which hormones, which they have to take in order to produce the eggs.
yeah.
But now in the market, is it available with us for us
No, right
now?
now in India we don't have
Yeah.
that specific drug that is a
Which is
long-acting drug.
long acting has been
Yeah,
introduced. Hopefully it will come into the
yeah,
market for us also soon. So the number of injections for them is reduced,
it's reduced. Yeah.
and the hospital visits are
Yeah,
also
yeah,
reduced.
but then we also have the pens, the pens that are
Yeah.
some patients who are clever in injecting themselves, or who have been injecting, shall we say, injections for their own family members, like for example insulin, etc.
Correct.
They can easily administer these hormonal injections for themselves, and they can also take it home, and then if they have a good fridge and a storage facility where they can maintain the cool chain, they can kind of
So
inject
their
themselves.
hospital visits will definitely reduce.
Yes,
So they don't have
exactly.
to come unless they really have the scans or the blood tests.
Yeah.
So the number of hospital visits can definitely reduce. And here, as far as the men are concerned, especially in our hospital, we
Mm.
have sort of fine-tuned
Yeah.
the technique of what is called microtese,
Mm.
which is specifically done for men with non-obstructive azoospermia, who otherwise probably would have had to go for usage of a donor sample.
Yeah, no. So azoospermia basically means no sperm in the semen, and it can be of two types, where the duct carrying the sperm from the testis right to the outside is blocked, that is obstructive, or non-obstructive, where the problem is in the either the manufacturing of the sperms itself, or the maturation in the testis itself. So yeah. So now can we?
So the thing, Dr. Devika, all this, what I want to again emphasize is, this is not recommended for everybody for every cycle.
Yeah, yeah,
You have to choose
yeah.
depending on what has happened in their previous cycles, or is this the first cycle?
Yes, and also we have already been talking also previously
Yes,
about
earlier.
in the earlier episodes as to how we individualize treatment, not only in the clinical side, that is our injections and the type of injections, the dosages, and what kind of treatment they're going to have, but also in the embryology side. So when we're talking about the latest advances, we're not really saying that everything needs to be applied to every patient. That is not the case. There are certain set of patients where we would suggest a few things, the others where we say, no, 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 don't worry about it, it's only your first time, you should get pregnant. Young women, unexplained,
Yeah.
infertility. So a lot of things like that. So what about the embryology side, Dr.
Yeah,
Jyoti?
now what this thing is, earlier also in earlier episodes we've specified that this has been happening in our embryology lab ever since its inception, is this double witnessing.
Yeah,
And I think that is something which has to be introduced probably in all the IVF labs, because it gives that extra kind of security for the patients.
yeah,
And we have introduced
yes,
this RFID, radio frequency identification for the couple. And like we had discussed in the previous episode, it's a special this thing where the all the details are come in the form of a card,
yeah.
ID card, which is given to the patient.
Yeah. and the patient should bring it every visit. And then
Yes.
they feed it into the computer, and then the patient's identity comes up, and then each one of the dishes that are used for the patient, that is the wife's dishes and the husband's dishes, the petri dishes in the lab, the
Which are
lab
all
dishes
labeled
are all labeled with
with
the
the same
tag.
kind of tag. Huh.
So and it's all loaded into the computer, so there is no question of any kind of a mismatch. That's the latest thing that we have, and I think
Yes.
we are the first ones in South India to have that. Otherwise, there are many other things in the embryology lab, many tips and tricks that we can actually kind of use, and one of them would be the oocyte activation factor, which we use quite a lot, and then it is mainly used for people where less than 50% of eggs have been fertilized by the husband's sperm. So you take the egg and you inject the sperm into it, and they should fertilize. Fertilization means the meeting of the combining of the
Sperm and
of
the
the
egg.
sperm and the egg. And if less than 50% of the eggs have fertilized, then that's when you would use the oocyte activation
So
factor.
that means to say they've had this in a previous cycle,
Yeah,
and they come to us
yeah,
with this report.
yeah.
Then we would suggest
Then we
this.
would suggest it.
Mm.
Also, for women with repeated failures, then we may suggest what is called as a cumulus core culture, where we actually have the you see, the eggs are surrounded by lots of cells, and these cells are very important in providing
They
nutrition and
call
lot of
kind of helper cells.
helper cells. Yeah,
Yeah.
they provide a lot of nutrition signals back and forth from the oocyte and back outside the oocyte. So we actually make a plating of these cells. So when the egg comes out, it comes out with these cells surrounding it, and we make a plating of these cells, and then we
Grow the embryo.
grow them, and then we put the embryo on top of it. So the good embryos will get attached to these cells, right? So that provides a little bit of an extra nutrition for and support for the growing embryo. So that is something that we can do. You want to tell us about the embryoscope?
The embryoscope is a highly specialized incubator, and we've discussed this in our earlier episodes also about the latest advantages. And basically, it prevents the changes in the pH and the temperature, because frequent opening of the doors of the incubators are not required. And there is a monitor which is attached to the front of the embryoscope, so the all that the embryologist has to do is to monitor the growth by just looking at that,
Yeah,
because there is a camera inside which takes frequent pictures.
yeah, yeah. So that's one of the good innovations that have come out. We also have laser.
Again,
Yeah,
again, not recommended for everybody.
again, not recommend for everybody. These are all the second
Second
line,
line.
shall we say, tools that we would use. Again, laser assisted hatching mainly for frozen embryos and embryos which have a thick
Thick.
shell.
Elderly women, all
Elderly
those
women.
kind of things.
Yeah. Also,
Repeated
if you're doing
failures.
IVM, that's another
Yes.
story. Then, of course, we have the pre-implantation genetic testing, where you can always see the thing is that for a pregnancy to happen, there is a contribution from the embryo of about 70%, and the uterus, the contribution of the uterus is about 30%. So, really, when the because the embryo contributes so much to the pregnancy, we want to put in what is called as a euploid embryo. Now, what is a euploid embryo? Euploid embryo is an embryo which is genetically normal. So it's like this: the embryo may look beautiful when you're actually looking at it. We usually do a blastocyst transfer for most of our, about 95% of our patients,
which is a day 5 transfer.
yeah. And these embryos may look good, but when you actually analyze them, you may find that they are quite abnormal genetically.
And before we had the in-house PGS testing facilities,
Yeah.
we used to think, oh, these are beautiful embryos,
Yeah.
and we definitely are going to get pregnancies out of it.
Yeah.
And we would be highly disappointed when we didn't.
Yeah.
And once we got this, we realized that even you can look very beautiful,
Yeah.
but you will have a lot of genetic abnormalities.
Yeah.
So that gave us this thing to counsel these repeated failure patients, that they require probably to go in for this PGTA.
Yeah, and it decrease the time to pregnancy more than anything else, and but then it's not a magic wand, it's not like everybody who has a genetically normal embryo gets a transfer and boom, they're pregnant. It doesn't happen. It may increase your pregnancy rate by some small percentage, but then for maybe 5 to 10%, but that's it, that's about it. It will not it's not a guarantee for pregnancy, because there are so many other factors governing that implantation process. So really, but then we don't have all the answers, but we have some, and we would like to use it only in specific patients, in specific cases, and it's not applicable to all.
All. And we always counsel our patients and tell them these are the options available.
Yeah.
And even then, like you rightly said, it's not going to give them 100% pregnancy. It's just going to give them a slightly increase in the pregnancy rate, and probably it's recommended because they've had failures earlier.
Yes, yeah.
So let's
right,
do
yeah.
something a little better.
Better, yeah. So also for the men, we do have men who come with what is called as a high DNA
DNA
fragmentation index. Again, there is a problem with the genetics inside the sperm. So we can actually separate the cells, which separate the sperm which have the high DNA fragmentation, and from the cells that have the normal DNA fragmentation, and only take those sperms and inject them into the egg.
Egg.
So that is called as the MAX system. And the yeah, so yeah,
Very
anything
common
else?
question.
Yeah.
Why did it fail? I wish we knew the answers
Yeah.
for all of them.
Yeah.
Sometimes even we
Hmm.
are equally disappointed because that particular case, according to us, everything went right.
Yes.
And she should have become pregnant.
Yeah, we don't have all the answers. I mean, that is why medicine is medicine, you know.
Yeah.
I mean, what we actually know, I think, according to me, is only the tip of the iceberg. There is so much that is not known and still has to be discovered, and that's what makes the field of medicine exciting.
Yeah.
Yeah. So,
So this thing wise, it's sometimes even 30, but on an average 40 to 70%, depending on which center you have.
yeah,
And lot of things about the center make a difference.
yeah, that we have also covered.
Discovered
It,
how long it's been there, what's the technology available, what's the clinical expertise, what is the embryology expertise,
Yes.
all that matters.
Yes, yes. The
Okay.
quality of the lab.
Yeah.
Yeah.
And in addition, of course, we've also found out that it's this try and try again. I know it's difficult, but we have found out that the pregnancy increases.
So you get what is called as an increase in the cumulative
Cumulative rate.
pregnancy rate. Yes, and the basic thing is that you get more eggs, and then your chances of success is higher. That's all there is to it, because you have more embryos which are formed, and you have better embryos to choose from. So if you have only 3 eggs and you have one embryo, you only put in that embryo,
embryo
whether
which
it
is
is
available.
good, bad, ugly, or indifferent. You'll have to put it and take your chance. So basically, that's how it works. And then when you have many embryos, you have many more attempts to put in these embryos.
You can have a fresh transfer and couple of frozen
Transfers, yes.
and all that adds to what we call the cumulative pregnancy
Yes.
rates.
Basically, unfortunately, we can't answer this question like,
Yes, come to us and we will make you
we
pregnant.
will make
No.
you pregnant. No, that is not. But we will definitely try our best. That's number one. Number two is, why did IVF fail? We don't have all the answers, unfortunately, and nobody can answer that, whether it is in India or anywhere in the world. This is again another question, when somebody is starting off IVF, especially the people who have not had an IVF will ask this question very, very
Yes.
frequently. People who have had an IVF, then their perspective and their whole approach changes to the questions. So, what do you think, Dr. Jyothi? How many times can I undergo an IVF?
See, we understand that for every patient, a couple, it's really a lot of financial, emotional, psychological burden. Every cycle is.
Yes.
Okay, and we want everybody to conceive in the first cycle.
Yeah.
But it doesn't happen. And like you rightly said, in our center right now, we have very few first cycles.
Yeah, exactly.
So, all of them who are coming having had repeated failures elsewhere. So when they come to us, we have to first, not just immediately say, okay, come, I'll do the IVF for you. No. Understand why, if possible, try and understand what happened in the previous cycle. Are there correctable causes?
Yeah. Yeah, correct. Yeah. And there is no point, like what you said, there's no point as soon as the patient comes, just hold them and start doing an IVF.
No.
You have to get down to the nitty-gritty, see if we can correct any correctable causes. Is there anything else that has been missed out in the previous cycle that we can think of and analyze it, and then do a correction and try to get them a pregnancy.
And in our center, we have, I feel, another advantage because we have so many seniors and consultants. So all of us put our heads in together and say, okay, this is what was the stimulation protocol, the drugs used in the previous cycle. But this is her situation and this is how she responded. So should we do anything different? And these ideas keep going backward, forward, and we come to a decision. It's sort of, a lot of people putting their heads in to understand why that particular patient did not succeed in the IVF cycle.
Yeah, and I think also one very important thing that I should mention is that we have a lot of audit meetings where
Yeah.
everybody sits down together, the embryologists, the clinicians, and we have a large number of clinicians as well as a large number of embryologists. We have 8 embryologists, and we have about something like some 7 consultants and some 8 or 9 the middle grade doctors who will all sit down, and then and we have our ultrasound doctors who will all come in and say, this is what happened, or the previous cycle she's had XYZ, and maybe we should do from the clinician side what we should do. The employers contribute and say what they should do. So we look at difficult cases, difficult patients who have had long histories of childlessness, and then we do actually put in all our heads, and then we do have these meetings. Also, one is how do we go forward, second is what went wrong.
What went wrong?
Yeah, why didn't
Correct.
expected embryos go on implant? Is there anything else that we can do? So those are audit meetings are very, very important for every institution to have, to look at their own results, to identify problems that may be there, to set right things that we feel may have just got out of balance.
Correct.
And also to get input from outside. So we also have some of our very good friends who are international doctors. We have one very good friend in Canada who is the head of director of embryology, and he will kind of talk to us and say, do this or do that. And whenever we are stuck, we always go to them. So that is a very open approach that we have in our hospital.
And also, suppose we do find that there are certain tests which need to be done, we will counsel them and
Yeah.
say these are the further tests which probably may not have been done in the previous ones.
Yeah.
And these tests will help us guide them as to what next to be done before the IVF
Yeah.
cycle.
Yeah, correct.
And the commonly things are like what you
like
said,
we have, sometimes we just see that the tubes are swollen, so they are called hydrosalpinx, and we've talked about it in our one of our previous episodes. We were talking about tubes. If you have a hydrosalpinx, that means a tube filled with water, that will not allow a pregnancy to happen. That's number one. Number two is also TB. I think genital TB is a very important aspect in our country, because a large number of women and men we are exposed to TB. TB is endemic in our country, so we have to actually look for it actively if somebody has actually had many cycles that have failed. So those are the few things that we would like to do, and before somebody again jumps into the next cycle.
Correct. And the other thing is, like you rightly said, the hydrosalpinx happens in the tube. Okay. But the problem is, if at all it is connected in the uterus, it has toxic fluid, which will come into the uterus, and when you put in the embryo, it will it is toxic to the embryo. So it prevents either implantation or it causes an abortion.
Yeah, and to look at all that, the patient may have had a laparoscopy once before. We may have to do it again. And it's a lot.
And if it is there, we are going to disconnect it.
Yeah,
remove the connection between the tube and the uterus.
Yeah.
And about genital tuberculosis, basically it is in the uterus.
It is in the uterus, and it's in the tube as well, and that can also be a cause for recurrent abortions or recurrent failures of IVF. And it's very easy to treat tuberculosis. It's not a big problem. We have fantastic drugs in our country. Only thing that the whole course should be taken. So there are a lot of aspects like that which we would like to cover. And also some people have, see, the thing is that IVF is not a very unexpensive procedure. It is expensive. The drugs are expensive, the procedures are expensive, and so sometimes people come and say, okay, I've tried everything, I've tried 3 IVFs with my own eggs and etc. And then also sometimes they may be slightly older, the older age group, 41, 42, with not a very good ovarian reserve. Then you might want to go into talking about donor eggs and the various aspects of that.
Especially if they've come to us, even if they've had previous failures elsewhere, we will suggest all that we have just discussed about the embryoscope, the PGT. And some of them, Papa, really agree and get everything done. Still, there is no pregnancy. Then, as a last resort, or if they really have the woman has a very poor egg producing capacity, or the men have very severe sperm parameters which are abnormal, then probably we would be advising them a third party reproduction.
Yes. So when exactly is the donor sperm advised?
So donor sperm, yes, when there has been, basically in my opinion, there is definitely a cutoff before you plan even an intrauterine insemination with husband's sperm. You cannot do for somebody who has a 1 million count post recovery, because it's not going to work. As such, IUI, in the best of centers is around 20%. And so instead of, in those particular cases where they severely compromise semen parameters, maybe a donor semen, in case they're not willing for IVF,
Yeah.
is recommended.
But there are some men who say, no, 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 donor semen is not an option for me. So that's it. So then what would we do
Then,
then?
because like I would just want to highlight here that even for men who are declared as having no sperms, what we call azoospermia,
Yeah.
there are two kinds, like you had mentioned earlier: the obstructive, and where it's a block in the egg, in the tube,
In the
which
passage, yeah.
of the sperm,
Yeah.
and the non-obstructive,
Yeah.
where even there is this thing from the testis itself,
Yes,
from
correct.
production.
Production.
So there are methods from which you can get out sperms, TZ and micro TZ, and we've done this and we've had fair amount of pregnancies.
Yes.
So the husband can still use his own sperm,
Yes,
without
yeah.
going for donor sperm,
Yes.
if they are willing for the IVF ICSI procedure, with these procedures
Yeah.
added on.
But we can't do IUI with
No,
some
we
sperm that
cannot
has
do.
been treated from the testes,
No.
because it never comes out like how it comes out in a ejaculated sample of semen. You'll only get 5 or 10 or
Yeah.
something, 15 or something like that. Anyway,
So that's as far as the semen is concerned. About donor egg, there's a lot of interest in donor egg now.
yeah.
And how successful is the donor IVF program?
First of all, donor eggs we would only first if the patient most often it happens because patients have a low ovarian reserve. That means they have exhausted the stock of eggs in their ovaries, and they are also fed up of trying repeated IVF cycles by themselves, and then they say, okay, fine, let us look at another alternative. Some of the other reasons could be advanced maternal age, which is again connected to a lower stockpile.
Yeah.
Okay. And the third would be there are very this is okay. Before I get to that, of course there have patients with repeated failures and where they do not have enough quantity or again quality of eggs. Their quality of eggs are repeatedly poor, so they would also opt for it. But one very important factor would be to talk about women who have premature ovarian failure. And we are seeing a lot more young women who are all in the ages of 30, 31, 32, 28, 29, who have just gotten married and then want to kind of enjoy their lives for a bit before they actually get pregnant, and they come after 2 or 3 years and then they find when they're 31 that their ovarian reserve or the stockpile of eggs has completely decreased. That is really, really disheartening, disappointing, depressing for these young women who have just started off
and
their
extremely unexpected, because you don't
Yes.
expect somebody who's of that age to have such a poor ovarian reserve.
Yeah. So one is that these women may be carriers of genetic defects, and that may be the reason why their stock of eggs are less. Or it may also be a situation where we have no idea, but then we're seeing a lot more of these women, and it could be environmental factors, environmental pollutants, plastics, what we eat, what we breathe. God only knows.
Yeah.
That's the only thing that I can say.
So the take-home message for everybody is have a baby early.
Yes. So when I was, shall we say, much younger, and and when I got married, I said, no, 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 we can't have a baby until we are, at least we know each other, much better, and see the world and things like that. That has completely changed now, and it's gone a complete metamorphosis, and then we are going back to our, shall we say, our elders' times when they say, okay, as soon as you get married, you should have a baby. So I think you must get married, have a baby, then have your honeymoon somewhere else. so so that's the situation. But jokes apart, the very important take home message is that young women are losing their fertility very quickly. We age about 5 years earlier than our Western counterparts. So if a woman of 45 who's 45, who's a Spanish woman, or a Western woman who's 45, we would have already reached that age of 45 at about 40 or 39 years of age. So please understand that it is important to pause a little bit, take a break, and think and say, okay, let me see what my stockpile of eggs are. And there are various tests that we can actually do to find out what your ovarian reserve is, and we can actually help you out there. So that's another topic. It's a completely different topic again. But then about coming to our donors are of a young age group, less than 32 years of age. They have had their own children. They have proved their fertility. We do all their testing that are required by the ICMR, as well as other tests as well, to make sure that they are good donors, and only then take them up. We do match their blood groups and appearances to some certain extent, and our pregnancy rates are pretty good, anywhere between the range of 65 to 75% with the donor egg program.
Certain among the, we were talking about the donor IVF also, genetic defects, certain genetic defects you think
Yes,
require
yes,
donor
yes,
IVF?
yes. So we have people who have the parents who are carriers of genetic defects, and quite often they only find out that they are carriers after having a genetically
Abnormal
affected
baby.
abnormal baby. So then we can actually well, for that also, if you look at the carrier status, we can also do a PGD, which is a pre-implantation genetic diagnosis. That means you test the embryos even before you put them in for this particular disease, and only then put in the healthy embryo, which we've done for sickle cell and things like that. We've got healthy babies. Otherwise, if the patients cannot afford it, the donor program is always there.
Yeah, and certain medical conditions like in case they are on a lot of these anticoagulants, DVT and all that, would you consider a donor egg in case they cannot come for their own IVF program?
Yeah, maybe, yeah. So freezing of gametes. You want to tell us about it, Dr.
Yeah, so
Jyothi?
SEMEN always, we ask for a backup sample, because many times we have seen when they come for IVF, we ask for a frozen backup sample, because on the day of OPU we've had many men who, with all the stress involved, are not unable to give a fresh sample, or they give a very poor fresh sample. At that time, we have either the option of vitrifying all those oocytes,
Vitrifying is
or freezing the oocytes without making them into embryos, or going ahead and using a donor sample, which is not acceptable to, neither of this is acceptable to the couple. So that is why we have a frozen backup.
Yeah, we have a frozen backup in every IVF cycle, mainly because a lot of the men, not lot, some of the men get very anxious and they cannot give a sample on demand. So then we always use the frozen. So that is one thing. What about the oocytes? What about the eggs?
No, even this thing. Sometimes the men are not available. No.
Yeah.
If they are not available for whatever reason, they are
gone off to some other part of the country and they can't come back, then we always have a frozen backup. Yeah.
So as far as the oocytes are concerned, one of the earliest one which we have always been doing is for cancer.
Yeah.
Fertility preservation for cancer treatment. But now we have started doing a lot of women are coming to us for social egg freezing.
Yeah.
And when we look at social egg freezing is for some reason, either because they are very climbing up the professional ladder, and they either want to postpone marriage itself or childbearing, they vitrify their oocytes.
Yes.
For further use whenever they want to make them into embryos and transfer.
Yeah. So that is again coming back to what I was talking about, young Indian women losing their fertility. So it's a good idea to kind of get checked and see where on the fertility scale that you lie, whether you are planning a marriage or whether you're not married, or whether you're not planning a pregnancy or whatever, or you still, or marriage is not on your radar. It may not be on your radar. You may still want to have a baby at a later stage. You may find somebody who is, who you want to kind of live the rest of your life with, and then have a baby with that person. So freezing eggs.
But then unfortunately your eggs are not going to be available at that time.
At that point of time, because the biological clock is ticking and it is not stopping for anybody or anything. So if you're 30 and you find out that your ovarian reserve is coming low, then the best option would be to freeze your eggs. And so it is like keeping a fixed deposit, keeping money in a fixed deposit which you're going to use for a rainy day. And if you do get married and get pregnant by yourself, great, fantastic, throw those eggs away. But if you actually have a problem at the time that you do contemplate having a pregnancy, then
these much younger eggs are available.
Yes, much younger eggs, much better quality, better fertilization, better babies, better everything. So I think we're going to be doing a complete different program on social egg freezing, so that we will touch upon that again. Some of the other reasons why somebody may want to freeze an egg at this point in time, because of endometriosis, or they are having autoimmune conditions where they are on a lot of immunosuppressant drugs, which can again decrease your fertility. So these would be some areas where we can actually freeze the eggs. So now, how long can we? That is a very common question. How long can we
Mm.
freeze these eggs and
Really,
sperms?
it's really not recommended that you freeze it for very long, because we have found out that the earlier, it's like keeping anything in the fridge.
but
It's
then,
like
but
that.
then,
The oh,
but then, to some extent, it's an extended period. You can have it like
yes,
for about at least 10 years, or and after 10, I think maybe then it comes down.
yeah,
And we definitely can freeze eggs and sperms for a long time, because once it is frozen, it goes down to minus 196 degrees, and it is like
stays.
stays like that. It's frozen in time at that point of
And I
time.
think now, especially with once vitrification came into the
Hmm.
picture,
Hmm.
unlike the slow freezing
Yeah.
earlier,
Yeah.
we know that the recovery rates are much better. The freeze
Yeah.
thaw cycle give better pregnancy rates also.
Yeah.
So vitrification is a good thing. And of course, we would definitely recommend that you use it earlier than later, because it gives
Correct.
you better pregnancies.
Yeah. Yeah.
And we also want to add that oocyte vitrification gives you better freeze thaw results
That means post
than
thawing. Yeah. So that
rather
means
than
after you
after
take
you.
it out and thaw every egg that is frozen, or every piece of tissue that is frozen, when you take it out, it has to be thawed. So
Hmm.
the post thawing survival rates are much better.
Better with embryos than with oocytes. But then, if you're not married, then you have to have oocyte freezing only.
Yeah.
And then later on,
Yeah.
this thing. That is why we want you to do it earlier, so that
Yeah.
you have plenty of oocytes to freeze.
Yeah, correct. Exactly. So we have come to the end of our FAQs, and I think we've answered most of the common questions
Questions.
that are asked. If are there any questions right now, we'll be happy to take them. Or you could please watch out for our next program, which is on recurrent pregnancy loss by Dr. Navya and myself, and we'll be talking to you at the same time next Saturday. And you always can text in your questions to ask@gunshila.com, and we'll be very happy to answer them. Thank you so much for being with us in this episode. Do we have any questions? No.
Thank you.
Okay, so thank you so
Thank
much.
you.
Looking forward to being here
Yeah.
again next time on Saturday at the same time. Bye.